Let's go to the very interesting talk by none other than our General Secretary, Dr. NAMRATA Sharma, Professor RP Center. She'll be talking about epithelial maps and refractive surgery. Over to Dr. NAMRATA.
Thank you, Dr. K.P. Kudlu and Dr. Sonu Goyal for making me a part of this national symposium. I think I'm going to be talking about a very important topic, epithelial maps and refractive surgery, which have actually become more important in the recent times. Now, if you look at the normal central epithelial thickness, it is about 50 to 60 microns, and the epithelium tends to be thicker inferiorly rather than superiorly because of blinking and friction of the upper lid, and nasally then temporally because of the blinking effect and the fact that the lateral canthus is located higher than the medial canthus. Now this accounts for about 1.03 diopters power of the eye in the central 2 mm zone and 0.85 diopters at the 3.6 millimeter zone. Now there are various ways of mapping the epithelium, including confocal microscopy, but the area of evaluation is very small here, and it's very difficult to correlate it with the screening of the refractive surgery. Then you can do it with a very high frequency digital ultrasound, which can differentiate the tear film from the epithelium. And you can also use OCT, but OCT is not able to differentiate tear film from the epithelium. Having said this, I think the easiest tool is the OCT, which we all commonly use. Now, it is important for screening of the patients of refractive surgery that because remodeling of the corneal epithelium occurs to mask the stromal irregularities. So screening of the early keratoconus is very important, which will show like a donut pattern, which is seen here. And it can differentiate suspicious corneal ectasias from contact lens warpage. So in the contact lens warpage, the thickening would be present, but it will be present not only in the thinned out area, but in the other areas also. Whereas here it is going to be a donut pattern where in the area of the thinning, there will be increase in the epithelial thickness. And so in the area of steepening also, the epithelium thickness would increase. And that is to mask the irregularities which are present. Now this is the donut pattern of a classical case of keratoconus. You can see on the pentacam map, and this is also highlighted in the epithelial maps where you have area of thinning in the area of ectasia, and subsequently surrounding the area of the epithelial thickening as well. Now, it is important to distinguish subclinical keratoconus from epithelial hypertrophy. In epithelial hypertrophy, the map will show that there is increased thickness in the area of steepening in contrast to the donut pattern which is observed in the subclinical keratoconus. So such patients can be screened in for your corneal refractive surgery. Now again, here to show that the area of subepithelial epithelial thinning corresponds to the area of steepening, and this is suggestive of subclinical keratoconus, and these patients can then be screened out of your LASIK or SMILE procedure if you want to undertake. Now this was a very nice study which determined the utility of the subepithelial thickness mapping in refractive surgery evaluations, and as per this study, whenever the epithelial maps were looked into, 10% of the patients were screened in with the epithelial map, 6% were screened out. The choice of surgery was changed for 25% of the patients requiring refractive surgery. 11% gained eligibility for LASIK and 8% lost eligibility for LASIK. But larger patients, important thing is, were screened in with the epithelial maps for the refractive surgery. Now, the concepts of epithelial remodeling is that it is going to depend on thickness and it is going to depend on curvature, but curvature has possibly a greater role to play, and greater epithelial changes are done for curvature changes to compensate for changes in curvature, although epithelial remodeling would also occur with the changes in the thickness. Having said this, whenever the epithelial thickness would increase in proportion to spherical equivalent, and increased ablation zone will cause lower rate of regression. In cases of hyperopia, you have a post-hyperopic corneal apical scarring, but there may be no changes in the central thickness, and in RK, there is no change in the thickness, but still there would be changes in the epithelial thickness. So I think this is something which needs to be kept in mind. After PRK, there's a significant decrease in the first month, and there's increase in the central epithelial thickness over 3 to 6 months' time. It becomes stable at 6 months, and the post-op thickening generally does not affect the refractive outcomes. Important thing is that greater increase in thickness would occur with higher refractive error, smaller treatment zone, and thinner pre-op epithelium. This is just to show a case of PRK pre and post-op, right and left eye, and just to show how the thickness varies. There's relative thinning of the central area and thicker paracentral regions. Now this is at 3 months, which also, this changes continues to occur 3 months, but it stabilizes over a 6-month period. So you can see that the 6-month picture, 3-month picture, there's hardly any difference that is there. After myopic LASIK, the changes in the epithelium thickness, like I said, occur, but the stability does occur at 3 to 12 months. And the largest epithelial response is seen in the first month when there's a minus 0.39 diopters shift, which can be minimized by increasing the optic zone and by optimizing the ablation profiles. Now, this is a case of myopic LASIK again, and this is just to show that how the thickness would increase in the areas as expected. So it's more in the paracentral area, and whenever there is a regression, for instance, in this case, in the right eye there was regression, in the left eye was normal. If you look at the epithelial thickness, the right is classically different from the left. And there is more regression in the right eye because of the epithelial remodeling that has occurred. There is no change in the keratometry which is seen, but because of the epithelial remodeling itself, the regression has occurred. In the hyperopic LASIK, like I said earlier, there is going to be an apical syndrome with decrease in the quality of vision. And the treatment for these cases is sequential customized therapeutic keratectomy. And Rinstill has clearly shown that there's thinning of the central epithelium by 2 microns for every 1 diopter of hyperopic correction. Now then you can have irregular epithelial remodeling post-LASIK. This is in a case of buttonhole, and the epithelial map has become very variable with thinning at some areas and thickening at other areas. Post-SMILE also, the epithelial thickness increases in the central zone, and Ganesh et al. Have shown how it varies for low, moderate and high myopes. And it also increases in the superior zone, again varies from 3 to almost 9% in low, moderate and high myopes. But there is no significant increase after 3 months. So this is just a case to show a case wherein SMILE was done, the pre-op right and the left picture, and the post-op the bottom pictures, where you can see that some amount of epithelial thickening does occur over 1 week, then it also occurs over 1 month. Now this is a study again to show epithelial mapping changes after SMILE, and this did show that there is increase in the epithelial thickness. This is another study which shows LASIK versus SMILE, and this concluded that it was similar for both the groups, and it correlates more with the relative curvature changes. Now we did a study where we compared in a randomized controlled study SMILE versus PRK, and our findings were also similar. There was a significant increase in both the groups, SMILE and PRK, but the changes were comparable in both the groups. And likewise, the superior and inferior epithelial thickness also showed that both the groups, in both the groups there was increase in thickness, but the change was greater for inferior epithelial thickness. So to conclude, epithelium mapping is a useful additional screening tool in the screening of patients for refractive surgery, especially useful for planning a hyperopic LASIK. And epithelial remodeling usually doesn't impact outcomes of refractive surgery, but in high myopic corrections, it can be one factor which leads to regression in PRK, LASIK and SMILE, and I think that should be kept in mind. And larger ablation zones can reduce the increase in epithelial thickening post-operatively, and in high cylindrical errors, epithelium remodeling can leave residual astigmatism in cases of SMILE, so one has to plan that with caution, especially when you're doing relatively higher cylinders, although SMILE doesn't allow you to do very high cylinders, but relatively the cylinders that it allows you to do for a SMILE procedure. So thank you very much for your kind attention.
Nice talk, Dr. NAMRATA. Just a query, supposing you have done a myopia laser vision correction, and you find that the epithelium has increased in thickness from say 50, 55 microns pre-operative to 65 or 70. Do you think this, and this patient has a -1 diopter residual error at 6 months, is there a role for just debriding the epithelium and not doing a recorrection? And if you do that, is the epithelium going to regrow to the same thickness, or is it going to go back to its normal and the error itself might get corrected? Because I did come across a paper where they have tried that for small amounts of refractive error. Any thoughts on that?
So if you're absolutely sure that the regression that has occurred, and there is a residual refractive, you're talking about regression, I presume, it is there and residual refractive error is there of -1 diopter, you can give a try of epithelial debridement and see how it grows. But I'm sure the response would be similar or could be even more exuberant than the first laser that you did. So we've not done any study or any case like that, but like you said, there is a study, it is a useful thought. But to my mind, I don't think it is going to make too much of a difference.
I just wanted to drive home the point, not just
You could try
pre-operative
that.
evaluation, even post-operatively. When you have a small regression, it might be a good idea to have a look
debride.
at the epithelial thickness. And if that's significantly higher, maybe as a first step, just removing the epithelium, letting it regrow might be a modality to see whether small amounts of residual refractive error can be taken care of by that.
I have not done any case like that, so I will not be able to comment on it. But then you do require, I think, a series of cases where you have residual refractive errors due to epithelial hyperplasia to, prove or disprove this point, which is difficult to get because you don't get too many cases of regression, although you may still get cases of epithelial hypertrophy, but you don't get too many cases of regression.
Thank you, Dr. Namrata. I think let us go to the next talk. We are short of time.